Hello and welcome. We're going to talk about a really sensitive but incredibly important topic today: recurrent pregnancy loss. Think of this as a journey, one that takes us from some really tough questions to the medical answers that can offer some clarity and, hopefully, a path forward. So let's start that journey together. This is the question at the heart of it all, isn't it? It's a question that carries so much weight, and it's exactly what we're here to unpack. The main idea to hang on to is that when this happens multiple times, it's often not just bad luck. It can actually be a signal that there's something specific going on that we can look into. So, to get started, we need to know the medical starting point. We're basically shifting from thinking about a series of painful events to a specific clinical term, which is recurrent miscarriage. But this definition is so much more than just a label. Recurrent miscarriage, or RM for short, is really a call to action. It's the official trigger that tells doctors, okay, it's time to dig deeper. It signals that there might be an identifiable and very often a treatable condition at play. Right, so once that signal is there, the investigation begins. And the very first step is to start exploring the main risk factors that have been identified through medical research. And just to give you a sense of how significant these underlying conditions can be, take a look at this statistic. Having polycystic ovarian syndrome, or PCOS, is linked to a 3-fold increase in the risk of miscarriage. That is not a small number. It shows a real, measurable connection between a specific condition and pregnancy outcomes. But of course, PCOS is just one piece of the puzzle. Investigators are really looking into several key areas. Things like autoimmune disorders, where the body's own immune system might be interfering with the pregnancy. They'll also check for thrombophilic disorders, which are basically issues with blood clotting, as well as genetic factors from the parents, and even a history of serious complications in past pregnancies. And this is what that looks like in practice. This is how those big categories translate into actual tests. See, doctors aren't just guessing here. They are hunting for very specific biological clues. For autoimmune issues, they might test for something called the anti-cardiolipin antibody. For clotting problems, they might look for the factor V Leiden mutation. Each test is designed to find a specific piece of evidence. So finding all those little pieces of evidence, well, that's what the diagnostic journey is all about. This is the practical part, how doctors and healthcare providers systematically go from looking at risk factors to finding a concrete diagnosis. It's a totally logical question, right? If you find yourself in this situation, what actually happens next? What does that whole process look like? Well, the investigation follows a pretty clear timeline. First, and this is really important, they usually wait about 6 weeks after the pregnancy has ended before doing tests for autoimmune or clotting issues. That's to make sure the results are accurate. Then, they'll run the blood tests to screen for those specific markers we just talked about. And finally, they'll often do what's called parental karyotyping, which is basically a test to analyze the parent's chromosomes for any underlying genetic factors. A huge part of this journey is also knowing which tests are actually needed and which ones aren't. So while screening for blood clotting issues and doing the karyotyping are standard for recurrent miscarriage, a test like a hysterosalpingography, or HSG, generally isn't. And that's because an HSG is a tool used to investigate subfertility, not recurrent loss. It's really about using the right tool for the right job. Okay, so let's say the investigation finds something. What happens then? This is where everything shifts, from diagnosis to action. It's about moving from understanding what happened in the past to creating a solid plan for the future. And I think this quote just says it all perfectly. The whole point of all that testing, all that investigation, isn't just to put a name to the problem. It's to build a rock-solid foundation so you can actually be proactive in the next pregnancy. Let's look at a real-world example. Antiphospholipid syndrome, or APLS. This is one of the conditions linked to those anticardiolipid antibodies we mentioned. Once a diagnosis is confirmed, there's a very clear, evidence-based plan. Treatment, usually a combination of aspirin and low molecular weight heparin, which are both blood thinners, starts right away, as soon as conception happens. This is a perfect example of how a diagnosis leads directly to a targeted medical plan. All right, we have covered a lot of ground, from definitions and causes all the way to treatment. So let's just wrap it all up and focus on the most important things to take away from all this. So what are the big things to remember here? First, that recurrent loss is often not just random. There's frequently a real, identifiable medical reason behind it. We've also seen that the investigation to find that reason is a clear, methodical process. We know for sure that conditions like PCOS and antiphospholipid syndrome are major risk factors. And maybe most importantly, getting a diagnosis, that opens the door to a proactive, targeted treatment plan for the future.
And that really leaves us with this final thought. The journey of investigation can be incredibly difficult, of course. But there's a powerful way to reframe it. Instead of seeing a diagnosis as an endpoint, maybe it's actually the beginning. The first confident step on a brand new and much more informed path forward.